Welcome everybody to the first episode of the Nurse Vitals PRN panel of frontline experts, we'll say. So thank you for joining me today. I just want to introduce my guests really quickly. We have Dr. James Simmons, aka Ask the NP. He is a board-certified acute care nurse practitioner, frontline healthcare provider, and an on-air medical contributor. We have with us also Casey Green. She has been a critical care nurse for 7 years, working in adult and pediatric ICUs, emergency departments, and as a critical care ground transport nurse. Casey is also a nursing clinical instructor and is certified across multiple critical care specialties. And we just asked her how many, and she said 7 and working on more. So you are an alphabet soup queen. Thank you. We also have Elisa Hambarchian. She is a registered nurse and has spent the past 4 years working in the Los Angeles Emergency Department. Previous to that, she has more emergency department experience as an EMT. She has most recently transitioned into working as a nurse practitioner in an acute care setting. And we also have with us Joe Castley. He is a registered nurse and currently serves as the coordinator for the Accelerated Bachelor's of Science in Nursing program at a California State University. And he's also a lecturer and clinical faculty for that School of Nursing. He is certified medical surgical registered nurse. His experience also includes being a staff nurse, team lead, and a charge nurse. So I think we can easily say you all have just mega frontline experience. And I think that's kind of what the show is about for anybody that's just tuning in. This show really got created as a result of the RN Mentor podcast not really being a place where we can discuss topics that are hot topics in the world of nursing. So that's why this show kind of got created. But I want to really kind of jump into the conversation of what this first show is going to be about. And this first show is about nursing errors and nursing medication errors. That is the hot topic of nursing, and it's impacting nursing in different ways. And nurses are kind of on different sides of the issue, to be honest, right? Some people are on one side and the other one's on the other side. We'll discuss what those sides kind of look like. But I'm going to really quickly go through and put everybody on the same page from a foundational level of what this topic, what ignited this topic, and for anybody who has not been on the news side of things. So we had Verdondava, who was arrested in 2019 and charged with reckless homicide and gross neglect of an impaired adult in connection with the killing of Charlene Murphy, who died at Vanderbilt University Medical Center in December 2017. The neglect charge stemmed from allegations that Vaught did not properly monitor Murphy after she was injected with the wrong drug. Vaught was to retrieve Versed from a computerized medication cabinet, probably a Pyxis for those nurses that are here listening, but instead grabbed becuronium, which is a neuromuscular blocking agent used in general anesthesia. According to an investigation report, Vaught overlooked several warning signs as she withdrew the wrong drug, including that Versed is a liquid, but Vec is a powder, which needs to be reconstituted prior to injection. So the injection occurred. By the time the error was discovered, Murphy was brain dead. So lots more nuances into this story of how everything happened. Hopefully we'll discuss some of that. But I want to just, before we get into the conversation, that it is with understanding that somebody did lose their life as a result of a nurse error. But what I want to hopefully discuss here is we can look at how those errors occur and the environments that we are in that really contribute to those errors, right? So it's not just it's not a single person issue. And we've been talking about that forever. That in early 2000, the To Err is Human report came out with the Institute of Medicine that put out that report. We have done a lot of work around trying to reduce medication errors, but we know they still occur. So having said that, I just want to kind of open up the floor as to how this story has impacted you guys, because I know there has been a sort of a negative impact on nurses practicing on the front line. Casey, I'm going to start with you if you want to share with us how this has impacted.
So for me, I've been very vocal about it, and I'm fully aware like errors happen, but someone still died because of the error. Fully, fully aware of that. But the thing that concerns me, both as a critical care nurse and as a clinical instructor, is what happens with the next generation. And we've been culture of safety, culture of safety, culture of safety. And when I came into nursing, that was, it was like known that the Swiss cheese model exists. And even at Hopkins, we've had medical errors that have changed like the system that in Maryland, and that led to patient deaths. And I think the thing that worried me right away is, are we then going to the next people that might make a mistake, are they not going to say anything? And what does that do for more patient safety, not accountability, but are people going to be so afraid that they'll be punished and go to jail over a mistake? And yes, it's very serious when somebody loses their life, but rarely is it just one nurse and one thing that led to that. There's usually a plethora of other things. So as soon as I heard about it when it happened, at first I was like, how could you do that? And then I started thinking like, I mean, there's probably a lot of ways that you could do that. So I think for me, it made me think of my own practice, and also in how I teach my nursing students to, if you make a mistake, fess up to it, get it right for the patient safety. This is all key. But it also kind of leads into like, okay, if you do make a mistake, now are people going to be too afraid to say anything? Or are the patients going to suffer from that?
Thank you. Very true. Very true. And that was one of the key things that I right off the bat thought is, how is this going to affect this culture of safety, or just culture, depending where you are? Some kind of a please be honest about errors environment has happened over the last couple of decades, and how this will impact that. So very true. Elisa?
Absolutely. I mean, I think we've all been in a position where we've either been so close to making medication errors or any healthcare related errors in itself, or we have made one, or we have seen someone make one, or we have assisted someone in reporting one or reported one ourselves. And having this case, I remember the first time I heard about the Verdondava case, it was a couple of years ago. And now I can't remember how it was, whether it was word of mouth, just through like EMS, because I know people who work all across the country, or if it was something covered on the news, I can't remember, but I remember hearing about it and I was so critical of this nurse. And I think I was probably a much newer nurse at the time, the first time I heard about it. I mean, I've been a nurse since 2018. And I was like, okay, which idiot gives a paralytic to a patient and just doesn't think twice about it? And then you work in a busy, dynamic environment. You get pulled to do things where it's not usual for you to give medications in a department that's outside of your own. All these different factors that I didn't think about in terms of the systems errors that could have went in to make this a possibility, and about how she addressed it with dignity, in my opinion. Like, once we now know a lot more about how she really was honest about it from the get-go, as soon as she realized the patient coded all this stuff, right? Now I'm like years later, now that there's more information coming to light with different perspective of my own, having now worked 4 years into it, most of my career almost in a pandemic, in an emergency department setting, I am so much more forgiving of someone for having the capacity to make such a big error. But at the same time, I'm just shocked at the environment we live in right now, in which we are prosecuting nurses and other healthcare workers for errors that have been happening for many years. and that are going to continue to happen. And it's just creating a very unsafe culture for future reporting, honesty, and for practice. I mean, liability wise, is this worth maintaining this career that might be quite difficult to do so, and on top of that might take away your own liberty, you know?
And I think you hit on a couple of good points. Is one of them is systemic errors, right? And like I
Mhm.
mentioned before, we have had a couple of decades of this just culture where we're addressing. Please come forward so we can address these early on. But also, I mean, as I was reading some of the material as they've been made available, I want to talk a little bit about that, of the culture of an environment and how that impacts some of the workflows that we have versus the policies that we have in those environments. Joe, you've been on both sides of, faculty. You have clinical students. You've also worked on the patient side. What's been your perspective as this stuff has come up?
Yeah, absolutely. I mean, I think, everybody's perspective so far has been really dead on, and I completely agree. I think the two things that really struck me about this case is, first off, there's been such an emphasis on the idea of just culture and thinking about systemic barriers and how we can, when an error happens, we do kind of analysis and we look at all of the causes and things that could be done to make sure that this doesn't happen in the future. And a lot of times those focus on technologies, warnings, things like that. But the environment within is really not discussed. And I think in this specific case, one of the big elements missing is that, initially there was a cover up by the institution that it happened at. And so you want to say, how could there have been a just culture at this institution if at every level thereon, the idea was not to protect human life or to examine how we could do things better the next time, but to try to sweep it under the rug. And I think that that's a really important thing, is that it's not just about purchasing technologies or putting warning things in place. It's about creating environments that people feel comfortable practicing in and reporting in. And I think that really struck me as a big deal in this case, because so much focus has been put on this nurse and not nearly as much focus has been put on this institution. And when we talk about creating these just cultures, we just can't do it with money. We have to do it, we have to do the work. We have to do the work to create these environments. And I think that that's really sad to me, because this sets a precedent where it's going to be harder to do that work. And I know one of the biggest things that, Casey can talk to this with students, what we talk about is making strong critical decisions. And to make a good critical thinking decision, you need to have good data, right? And you need to be trained, but you also need to be confident. And if we continue to create environments where people can't be confident in their practice, we're going to see more and more students coming out of nursing school scared. And when students are scared or clinicians are scared, they either don't act on things that they know they should act on, or they make poor, uninformed choices. And I think that to me is really what hit me when I learned about this case. And what I'm really concerned about is, how are we going to create environments that are safe? Beyond just simply the kind of physical things we put in place, but the cultures, when we say just culture, it's the culture that matters. It's not just, is the EHR effective, or do the warnings show up, or did she scan the barcode? And so that to me is the bigger issue, both for students and for clinicians.
Yeah. I agree. And one of the things that actually came out in the best investigation, which was reported, is that the Tennessee Bureau of Investigation agent reported, it appears to support defense argument that Vought's fatal error was made possible by systemic failures at Vanderbilt. Vaught's attorney has described his client as a disposable person who was scapegoated to protect the invaluable reputation of the most prestigious hospital in Tennessee, right? So when we know everything that has happened, and for those of you who don't know, when the error happened, there was some kind of a cover up by the organization. It wasn't reported properly to all the appropriate agencies. The family was at some point given money as a, hey, let's not ever talk about this anymore, by Vanderbilt. And there was an anonymous tip that said, hey, this is what happened at Vanderbilt. And that's when the investigation happened. And all of this came to a head, where this one nurse was kind of put out there. And you mentioned systemic stuff. And I guess at the time they were going through some kind of IT issues where everybody was hitting these roadblocks to trying to get into the Pyxis, or the computerized medication system that they have, a dispensing system, and overrides, right? So she overrode the system and removed um, the wrong medication is what she did. But I want to talk about that in a bit. But James, real quick, I want to kind of touch base with you, because now you're in the position of, not only do you have experience as a bedside nurse, but you also now are in the position of prescribing to those nurses. How has this affected the nurses that you work with, or how you might be approaching your work now?
Well, and I think now I'm going to be in the position of maybe being the bad guy a little bit, Dr. Tayeb, because I think we need to look beyond the surface level conversation that's been going on with Miss Vaught and Charlene, who lost her life. And I think all of this is great. I totally agree. And we've been having the same conversation in nursing for 40, 50, 100 years. And so, yep, you're right. It is the system. But I think, Joseph, you started to touch on something that I think is really tremendously interesting. And that is nurses being confident, is how you put it, but understanding the autonomy of our practice and the ownership of our license. And I think we have to, with the understanding that the system is completely broken, and I would blame capitalism for the broken healthcare system. Okay. And so until we start hitting organizations' bottom lines, until CMS actually starts withholding compensation for medical errors, actually starts penalizing these organizations, nothing's going to happen. We can march all we want. I'm glad they're going to march the day before her sentencing. It ain't going to do a damn thing. We also have to step back. I think we are at a flashpoint in our profession and actually look at how are we educating nurses when they come out of school. I am the first person. This also makes me very unpopular. Elisa, you are a new NP. You may agree with me. I went to what I would argue is the second or third best acute care program in the entire nation. I was woefully unprepared to be an acute care nurse practitioner when I started. We don't educate our nurses in the right way to do the things that we're doing and then to survive in these broken systems that we're all very clear are broken. And so you have a nurse who's the help all nurse, great. She's been a nurse for 2 years, apparently an exemplary nurse before that. What in her, and maybe this is the personal thing, right? Maybe it's Verdondava Case's issue, but what about our profession did not prepare her to actually be able to just stop and be like, this is my license. My sole job is to protect this patient with my license, with my autonomous practice. And so 13 times she had an opportunity to pause and say, let me go on ahead and protect my license. Let me go on ahead and just really think critically about this. And as a former critical care nurse who has mixed plenty of vecuronium, you're mixing vecuronium and this is Versed, right? We all understand that. But I think that there are some things that are a little bit more critical and a little bit deeper dive that we need to do as a profession and take a look at what, because there are thousands of these medical errors that result in thousands of individuals either losing their license, having their license temporarily suspended, certainly being fired, right? This happens to nurses all the time. What is exceedingly rare is someone being criminally charged and then actually convicted, right? So exceedingly rare being criminally charged, even more rare actually being convicted. But all this jury was asked to do was deliberate beyond a reasonable doubt. Did this individual in this instance stray from the standard of care? I'm not going to be popular for this. While I 100% believe the system allowed Verdondava Case to do this, what also happened was that in a jury, it got to a criminal case, a jury said, I feel like none of us are lawyers, I don't think, and we could have prosecuted this case, right? She clearly multiple times deviated from the standard of care. So how are we failing ourselves as a profession by continuing to allow the systems to be bad? I feel like ever since I started nursing, we're like, the system's bad, the system's bad, the system's bad. Well, I think we need to think about the ways that we can impact the organizations where we work, where we practice, the way billing systems are structured. Why don't we get to bill for our services? All of those different things. We are a clearly expendable part of most people's bottom line. How can we really address the systems, understanding that, at least in my opinion, in a capitalistic environment, in a healthcare system that we spend more money on healthcare than anybody else, but we have the 30th worst outcomes, can we hit people's bottom line? Because the only thing that will force change is money. And so I love the ANA's letter. That was great. I love the AANP's letter. That was great. I loved everyone's letters and support and all this stuff. But what are we doing to Vanderbilt's bottom line? Why did the DA decide to execute prosecutorial authority and prosecute her years later, but not Vanderbilt? It's those things. I think it's all great. Everyone made amazing points, and those are very true. But multiple truths can exist simultaneously. It's very true that the system caused this to happen. It's very true that Verdondava screwed up and somebody died because she screwed up. And we don't like to do this, but I think we got to look at what percentage of this as a profession do we own, because we continue to allow ourselves to practice environments that are unsafe. You can quit your job and find another job. We all know that they're hiring nurses left and right in some place, not at Vanderbilt anymore, but they're hiring nurses left and right for contract jobs and whatever. You can find another job, but if you lose your license, you can never get another license back. So
but I think that plays a part into it though, because then it's like, how do you, multiple things can exist at once, right? So at 2 years, let's look, like I was starting with like, oh, it's going to be polite. At 2 years though, who in their right mind, in what
be polite.
business, what place ever, like when I started as a nurse, I graduated in 2014 and I worked in a place where you did not even think of saying charge nurse, preceptor, nothing until you were 3 years in. That was like the bare minimum that anybody would speak to you about doing it, because they wanted you not just like, oh, you're really great on the unit, which I feel like is like the biggest way that we tell ourselves like, oh, you're so good with patients. Like, no, you still have no business being in those roles. But the idea that like at 2 years in, which I think it was less than that when she actually, like when the event happened, she was like at like a year and a half with orientation as a new nurse, that she's precepting someone else and the resource person is just beyond me. So it kind of starts with like, okay, people graduate nursing school and they are woefully unprepared to then go and take care of people. And you know, we can tell people, I tell my students from day one, like, you are in this, like your license is yours. Like you will never have to, you have to renew it for the rest of your life. You never have to take the NCLEX again, but you can't lose your license. And people will try to take it. And I say it's not right at all, but we're the last line. So you always have to think who is messing up. And while I don't actually agree with that, I don't think that our profession should be catching everybody else's mistakes. We are the last person before it gets to the patient, before they go for anything. But then at the same time, then when we're like, oh, well, capitalism, yeah. And it's like, well, every single nurse in America quit and went and worked a travel job and left those novice nurses by themselves out there in the world. And nobody, I mean, to be fair, yes, nurses should be paid more to do charge nurses and to be preceptors. And I think that we have to start saying like, we're worth that money. Like we are worth, like, and not being like, oh, well, God's calling, this is nursing. And it's like, yes, we still have to feed our families. When I started, and I'll be completely transparent, I grew up in Howard County, which is like the third wealthiest county in the country. And as a nurse, and we had to move an hour away in Maryland because we couldn't afford, my husband's a paramedic and I'm a nurse. So we could not afford to live in our own community, even though we work in communities that we live in. We can't afford to live where we work. So I think it starts there too. Like you have to start demanding the money, but at the same time, there always will be, it's been like this from the beginning. Like, I think when I was a preceptor in the ER, we had 6 new grads and they were being precepted by people who were a year themselves. So no, they would not learn. I mean, my orientee learned that vecuronium, we actually, when she was brand new, she didn't even know that vecuronium was a powder. She thought that it was just liquid, or people think that vecuronium is a powder because it's not, it's a strong paralytic. No, it's because it's not stable if you reconstitute it liquid form. But some forms of it have that. So it goes deeper than competing. I completely, like, what happened to Redonda, like if she lost her license, I would have been fine. But also, in what world do people get you go in front of your own profession so that your own profession can say, yes, you made this horrible error, but you didn't go to work saying, I'm going to kill somebody today. And I think that that's the difference and why it still doesn't sit well with me. But I think that with this though, it just alienates our career even further, where we start thinking, oh, like I just sat with 5 nursing students last week, convincing them that it's still worth it to become a nurse, because people just see like us being treated like straight garbage out there in the world. And it kind of, like, my push recently has been, nurses, like, I have 7 to 10 years. So we're going to start getting those seats at the table, because I think the public is starting to realize that, like, nurses kind of watch out for us. We've been the most trusted profession for a long time. Why isn't the nurse the CEO of the hospital? Why isn't the nurse the person who's making these policies? So I think that while we need more nurses that have experience, I think we have to change the narrative of nursing being seen as bedside, being seen as a stepping stone to go on to do something else. Like, the people who, you talk to a nursing student and they're like, I want to do my year so I can go to CRNA school. And people who are invested in being at the bedside or making changes or staying at the bedside and promoting into leadership roles where they can support people.
I agree. I want to touch back really quick with what James mentioned of sort of the accountability piece of the profession of nursing. Because I feel like if we had like a AA version of medication errors, I would be sitting here and say, my name is Ali, I have made a medication error, right?
Every single one of us should raise
Right?
our hand,
Like,
because I'm sure we have,
so
right?
I've been in healthcare since I was 19 years old. First in the military as a Navy corpsman, where my first job was at the Naval Medical Center, San Diego, and we were passing out medications as corpsmen, right? Not a registered nurse, not a, we're as Navy Corps, we were allowed to give out medications. So, I can probably count on one hand over the last 30 years of my experience that I've had medication errors. But I think the reality is medication errors happen. Here's what I want to kind of try to untangle a little bit. How much of the culture of how medications are dispensed by nurses, how much of the culture of the unit or our practice has to do with us making medication errors? Because every hospital sort of does a CYA. This is the policy. This is what you do. Here's your 5 rights, 6 rights, 7 rights, 8 rights, 9 rights, 10 rights. I've seen 10 rights. So, like, who's going to follow 10 rights of medication administration? That's just asking for people not to follow it, right? But it's a CYA. So how much of the practice of sort of like, oh, this is what we're supposed to do, but this is how we really do it, right? How many of you have kind of experienced that, but then, things happen? So that's a piece like nursing owns, right?
I think that's every day. And I think, Casey, you're on my right or left, whichever way. This is why you're probably below me on the actual recording, but I'm gonna point at you this way. I want to be super crystal clear about this. I think that sometimes when we you know, the whole adage that we eat our young and we're really hard on ourselves. This is not, I'm not trying to bully our profession. I also don't think that we just do more of the same. Like, I feel like this, when I say the onus is a little bit on us, there's a certain percentage of this as a profession that we own. It's not that we should do what we're doing harder. We have to be creative. We have to, because I think that while I felt woefully prepared to be an acute care nurse practitioner, like running an ICU when I first came out of there, I did feel pretty prepared after I passed my NCLEX to be a bedside nurse, because I think the way we educate is really good. But I think the other some other things have to happen, and we have to really force the issue, like what Casey was saying. Why aren't there people who are decision makers that are nurses? And why are we not having specific pathways for that? Why are we not encouraging that necessarily? Like, I still, to this day, I have medical students, residents, baby nurses, nurse practitioners. I teach all of them. And still to this day, like, there's this adage about, like, I have to do my 3 years of bedside, and then the only thing I can do is either become an NP or teach afterwards. Well, right, exactly. The educators are shaking their head, right? Everybody, y'all, right. That's not true. There's absolutely no reason why we can't have a 19-year-old who's in a nursing school at Cal State LA right now think that they can become CEO of an entire hospital system and actually make the change. I think collective actioning, get it, Casey. I think collective actions have to be a part of this. You know, I say what you will about some unions, but the data is super clear. In a lot of places that are unionized, a lot of these mistakes are less lethal. They happen as frequently, but there's less bad patient outcomes. I think there's some other things that we as a profession, we just got to sort of dial it back and be like, okay, we get it. It's wrong. It's bad. Verdondava, I think, is an outlier, and we can argue the pros and cons and, you know, why didn't they do all these things? But at the end of the day, I'm with you, Casey. These nurses and nurse practitioners that I precept and teach are scared out of their minds because the system is so crazy. I have seen travelers onboarding new hires in the middle of this pandemic right now because staffing is so crazy. You know, in California, we're famous for our nurse to patient ratios, which went completely out the window in 2020 and are still completely out the window, right? It's not happening whatsoever. And so I think that environment is really scary. You asked me this question probably 800 minutes ago, Dr. Tybin. I'm just now getting to it, but I am much more careful about my prescribing practices, whether it's interventions or medications, depending on the nurse that I know is taking care of the patient and the unit that they're on. If I know that, like, our neurotele unit is constantly a nightmare and it's just crazy. It's just, there's too much going on and I've seen mistakes happen and things there. I will literally go up to the patient's room, put the order in the computer, standing next to the nurse, and just like sit there and wait until it happens. Like, because I want to make sure that this happens in the right way. I shouldn't have to do that, right? But that's the world we're living in. And my hospital, your hospital, everyone's hospital who's listening and watching this isn't going to change until their bottom line gets impacted and they are forced to really implement the things that we really need. Verdondava was failed, to your point, Joseph, by, I think 7 of those 13 things were EHR related checks, were automated checks that she, cool, bypass. Who has not bypassed something in the Pyxis in their career? Like, we all do it. And so I don't want to necessarily beat up our profession, but I also think that we have got to, with new leadership in hospital systems, in academia, and all of these places, we have got to come up with creative and different ways to get multiple seats at the table, not just a seat, and not just as the CNO, but get seats at the table where we can actually make change and understand that change has to be driven financially because we live in a capitalistic environment, whether we like it or not.
Yeah, I agree. I actually, one of the things I always tell my students is, like, whatever you're looking at, look at where the dollars are, right? Because that's how change happens. That's why policy happens. That's why politicians get all excited, is because somebody is making money somewhere or somebody's being denied money somewhere, and that's why change is occurring. Joseph, you had something.
Yeah, I do. I mean, great discussion. I kind of agree with Casey and James both equally on the points they're kind of contending here. I do think that Casey's right. One of the big issues is that this makes everything more challenging, and that's why nurses as a profession are really up in arms. But I do think that James has hit on a really good point, which is that beyond just culture, we all know that there is a lot of poor, negligent nursing out there, and there's not really a good mechanism to address that. And I think to your point, Dr. Tayeb, where you asked kind of what onus do we have? I sat on a peer review council at my hospital. And when we made the transition from from non-barcoded medication administration to barcode medication administration, for 2 years after that, every month we would meet, somebody would have made a wrong time error because the nurses were just assuming that because the computer had a due time there and they scanned it and it didn't give them an error telling them that somebody had given the medication, somebody had hung an antibiotic late. So now the amount of time between when the antibiotic should be due and was actually due hadn't been updated in the computer. Every month the nurse made this error. And presumably prior to barcode medication administration, they checked the previous due time, right? But because this new technology showed up, universally we were seeing, and this wasn't just new grads, this was experienced nurses. And some of the poorest practice I've seen on the floor has been from people who've been doing this for 10 years. So who knows what other errors have occurred. And I think that James does have something right, that there is something to nursing's responsibility in all of this. And I think that we can't let that slide by, and that we need to think about mechanisms beyond just culture to address poor practice in nursing, because there certainly is a poor practice element here. And I think everyone in nursing is vulnerable to that, as we can all attest, from the new grad level, but up to the experience, because I think that, lack of preparation is dangerous, but complacency is dangerous as well. And I think that this case kind of is a little of both, even for a new nurse. And I think we see it a lot in our kind of more experienced nurses. And I think that we need a way within our profession to kind of self-police and to encourage practices that are beyond just relying on technologies and the hospitals to provide us with ways to improve our own professional practice. And I think
because the hospitals clearly aren't, right? What they're going to do is throw you under the bus.
Yes,
they're going to donate some money to that DA's campaign fund, so that, because remember, the district attorney who decided to prosecute Verdondava years later is an elected position. Vanderbilt University Hospital Systems is one of the largest employers in Nashville. I will not be a popular person. People probably gonna come for me after this, but why do you think he went after her, scapegoated her, and not the hospital? And so, Joseph, I love your point right there. We have got to, I almost make this akin to, and I'm not trying to dominate here, but I make this akin to, sometimes, we're not surprised that this happened. As a Black man who understands how socioeconomic issues and racism and the racist system that we live in perpetuates the school to jail pipeline and perpetuates this young man who may or may not be in a situation where he had to commit a crime or something, and then he's the one that gets punished and goes to jail and then stays in jail and keeps going in jail, and we blame him. And then we're like, well, Black folks, y'all better do something about your people. Let me be honest. I'm not going there because that rubs me hell of a wrong way too, right? This is a system thing. So I very, very much get this. This is why I say, to your point, the hospital systems are clearly demonstrating time again, and I'm clearly ruining my career ever going to be an administrator by saying this, but they're, at the end of the day, not gonna support us. They're gonna figure out a way to throw us under the bus.
And here's the thing, and how much, your points are all well taken, and how much of this has to do with nursing owning nursing once the nurses get to the hospital, right? So education departments tend to be really bare bones, right? And then when we talk about nurse competencies and ongoing nurse education, right? Usually it's an annual competency. You go into a room, you do some check marks or stuff, and then, oh, you're a competent nurse. How much of this stuff really has to do with us having, usually most hospitals have a minimum time that you have as a new grad, 8 weeks, 12 weeks, whatever, depending on your specialty, and then you're on your own. Very few hospitals out there have residency programs, which we know we get better outcomes with, and longer nurse retentions with reduced errors due to residency programs. And then looking at, from a competency perspective, looking at nurses in action versus, yes, I know you know what you're supposed to do, but are you actually practicing what you know you're supposed to do? Is the environment that I put you in conducive and allows you to do what you know you're supposed to do, right? How much of that do we own? Maybe
I'd
I'll
like
go, I'll go to Elisa real quick, just because I know you, it hasn't been that long since you were in a new grad program.
Oh, yeah. So I'd like to make a point about that. I think, one, we need to first understand and recognize how much power nurses have, even less so as a new grad, but once you get a little bit under your belt, you have so much power in where you choose to practice. And I think so many people often stay in so many jobs with organizations that have questionable business practices, on top of questionable patient care practices, on top of questionable training programs. Let's just say, without incriminating my first ever nursing employer, I reluctantly chose my first new grad position in a very small community hospital where the values did not align with mine whatsoever. And I left as soon as I could, simply because of safety. And at the end of the day, I knew that my license was on the line every single day I went to work, because there was no such thing as ratios, despite it being in Southern California and Los Angeles. And the moment you would say the word ratios, the ER manager would look at you and say, there's no such thing, you're in an ER, and think that you're a moron who doesn't know how to read California law. So as a nurse, it is our responsibility to take pride in our own profession. It is our responsibility to value our license and our lives ourselves, and not endure that kind of abuse, I would say, because at the end of the day, that is just coming down on your patient care. And at the end of the day, when something happens to your patients, you're liable for it. And if you don't have a safe place to practice where you could speak up about practices like not scanning medications or having anything to scan them, or not having a Pyxis machine to pull your medications out of, and you're doing it out of drawers or cabinets, it could be your license on the line. So that's one of the things. And just short of just having to become a CEO of a hospital or a CNO to make great change, I think the number one thing we could do is step away from these organizations that don't do any service to the public by being open. And if you don't have nurses to staff a hospital, those hospitals are going to be suffering. And financially, that is one great way you could make them suffer. They're going to realize, why do we not have any retention? How could we get our nurses involved in making changes that are going to make it lasting changes and allow nurses to be retained in the organization, you know? And so I'm a firm believer in leave an unsafe practice. And as soon as you notice, even just like in a one situational kind of timeline, if you notice something is unsafe, speak up, ask for help, say something. If you're uncomfortable, say something. You do not have to go with the status quo in your organization just because you feel like you are indebted to them because they are paying your paycheck. You're providing a service at the end of the day. And so I think that's the biggest thing we can do. We need to really take pride in how we do our jobs and do it well. And I think that's something that not a lot of people are focusing on now.
Can I just say, as the East Coaster, like when you were like ratios, I was like, hell, ratios.
What ratios? I know.
Those.
Right.
But I will say, look, we, especially like in Maryland, we are very like, you know, we'll mention California's ratios. And we'll always say like, oh, those, because, you know, over on the East Coast, we follow California for the most part. You know, our ratios exist because California has ratios. So the idea of like, you know, we're not going to double or triple you if you have somebody on this trip, or, you know, hey, you might have 5 priority 4 patients, but they literally don't need anything, versus you have somebody that's getting like TPA. So I think it's interesting too, like to hear like, oh, for ratios, because, and I think too, like we should really stop hating our own people for leaving environments that aren't safe and hospitals that aren't. Like the you're a job hopper thing. Like if you leave a place that you either can't stand and you feel like your practice is threatened, or your mental health, or just the environments. And I feel like we unfortunately, like I think the unpopular opinion is we do own this as nurses. We move on roller skates because people let us. Like I've told people before, I don't care. I need to stay in the room with the patient when I start the blood transfusion. So that's great that you room somebody, but they're going to have to wait. I literally can't leave the room. It's the first 15 minutes, and this person has had a transfusion reaction before. So write me up. Like we can talk to the manager in the morning about why, you know, this competing thing of like, oh, well, you have to see your new patient. And I feel like in nursing, sometimes we just love being miserable. Like misery loves company in our profession. And we just love, like, people are like, well, I had to do it like this in the 80s. And it's like, okay, times are changing. Or
That's-
I had a horrible orientation somewhere where it was like halfway through, I ended up precepting myself and I grabbed the wrong neb and our scanner wouldn't work. So I was like, oh, I can just, well, it doesn't work. So I've got the right medication. I'm gonna look at it 3 times and I still gave the wrong medication. So, I mean, it's like they happen, but it's because we allow ourselves to move so fast sometimes that I think we think, oh, well, our eyeballs aren't deceiving us. But also like just systemic things that can help us. Why in God's green earth does a medication, when you try to pull something out, does it not have brand and generic? Like I know a lot of brand and generic medication names, but in the 3, when I'm running to grab a medication for somebody and I already had to override it because things aren't working, my tolerance is 0. And to not be able to look up something like that, you have to look up midazolam, which, and the idea in nursing too, that some medications we call them by their brand name, everybody knows the brand name, and then other medications like TPA, for example, okay, cool, find me Ultraplace and in the Pyxis, which you wouldn't because it has to come from pharmacy, but like just the but just this idea of like when you work someplace and you own your practice, you know what things look like. But I've had a lot of people say like, oh, well, she should have known the vial, that obviously Versed comes in a dark vial, and it's like depending on where you work, so
right?
everything looks different. And this idea that like, people come out with an associate's degree and like we're not pharmacists, but people expect us to be. And like, we own our profession. Like, absolutely, you need to check your medications. But like, if 82 things haven't happened right, that's when you have to step back and say, like, I need to go get a scanner or something because it's not right. But just, and I think too, as nurses, we allow ourselves to get caught up in the stigma of the hospital we work for. Because I've worked from everywhere from little itty bitty community hospitals to gigantic, large institutions. And really especially on the East Coast, there's no difference in any of these places. They all have the same problems. The difference is sometimes the community places are more willing to listen, even though people will say, oh, we believe in just culture. But just culture goes more deeply than somebody makes a horrible error. It's like you kind of think to yourself, okay, how many times did I look at this problem? And how many times does somebody pull the wrong medication because only the first 2 letters trigger a medication to come up versus putting the whole thing? Or how many times did people pull the wrong medication because they put in the brand name and the generic name's what's in there, which that argument doesn't work either, because where I work at Johns Hopkins, we have both. So some, it only comes up with brand, and some it only comes up with the generic. And it's like, then you have to open up the computer to look. And it's also just, I just feel like there's so many nurses that are like, my practice is sacred and I could never make a mistake. And it's like, okay, every time you have allowed a patient to refuse meds, like the meds, and you haven't notified anybody that they refuse them, they have the right to refuse, but you have to document that let people know that they refuse their blood thinner medication 8 times, or you give a nurse dose, which shouldn't be doing that, people. Nay, no nurses. Get in order for the right thing, because then when you go back and 0.25 didn't work, but you really gave 1, then when they give them that, your patient will bottom out. So just, if you think that you've never made a med error, like, we're not perfect. And I feel like we have to like stop thinking that we're like these perfect angels. We can make a mistake just like anybody else can. But also at the same time, we have to realize like, it is a very special thing to be a nurse. And I think that some people, like personally, I will scream from the rooftops how excited I am to be a nurse. All the letters are great, but they don't mean anything if you don't actually practice what you preach and you don't like really, really care about your patients. And we all do. But I mean, I've caught myself thinking, I need to not be complacent about this. I really need to pay attention. And changing my specialty to pediatrics and working in a pediatrics unit, all your complacency is like, bye. You double check every dose of medications. You give a lot of medications with another nurse. You draw up medications with the nurse in the room, in the med room, when you waste meds, which a lot of people don't do. They just are like, hey girl, can I get a waste real quick? Okay, yeah, you're gonna drop the right thing. and like insulin, you just double and triple check. And I think sometimes with the monotony, especially being a critical care nurse where you drop 82 meds in a shift, you kind of think like, oh yeah, it's gonna be fine. I've done this a million times. And you kind of have to think like, okay, this is the third time that I've done this and I need to really, really check everything that I do before I do it. And if that slows you down, so be it. Like people will live without their Tylenol for 2 seconds. Slow down, it's okay. Tell them
And
they
the
can't.
hospital will live if their throughput time sags a little bit from that ER, because all of a sudden they know that we're not rooming patients until that nurse is ready, right?
Yeah, tell the nursing supervisor it can wait.
I love that example, right? And so, where do we as a profession get past the stuff you were saying, Casey, about like, oh, I'm perfect, we never make a mistake. I almost feel like because we are on the I just forgot the charge master for a lot of hospitals on the charge master, we're the same place as a Chuck, as a box of tissues, right? We are a line item. And until we are respected as an autonomous practice, until we are allowed to have privileges, until we bill for the things that we're doing, until we have committees that actually influence how the hospital has a relationship with the community and all of those things that, and then actually affect the bottom line. When you're looking at the charge master, well, nurses, okay, well, that's fine, but we're certainly not going to hire another nurse that could stay with the patient because we want our throughput times to be really fast, but we also want that patient to stay. We're not going to have a help all or a resource on every floor. That's too expensive because she's demanding $62 an hour or whatever she should be demanding. Like all of these things, I think are so, I'm glad that this is bringing so much of the conversation forward and that we're having an opportunity to talk about it. And I feel like with the uniqueness of Verdondava's situation and coming out of the pandemic, I'm super passionate about fighting. Like now is the time for us to sort of dig deep. Like let's have the Verdondava conversation and we can land on both sides of wherever. But okay, now let's dig deep. Like how are we gonna really move forward as a profession after this pandemic where someone's tweet, the one of the hashtags on Twitter has been, I won't say it, but it's F around and find out. Have y'all seen that on Twitter? And that's because Vanderbilt has like hundreds of nursing jobs that are going unfilled. And they're like, well, I wonder why Vanderbilt's having a hard time hiring nurses. F around and find out. Yes, that's the energy we need. We don't need the energy of like, oh, we'll just, we'll hire a couple of more travelers and just keep going, doing what we do, more of what we have been doing, which isn't working. Like F around and find out, but in a constructive, strategic, focused manner that is really going to influence decision makers while we also try to become the decision makers.
Yeah, totally.
Yeah, I agree.
Yeah.
I just want to be cognizant of everybody's time. If you want to take like a minute each for last word, what do you think our next step should be? Joseph, you go first.
Sure. I mean, I really appreciate listening to everybody's perspective. And I think listening to that kind of final discussion, what popped in my head was like, whether it's this med error case or COVID, we are in a unique opportunity to rethink a lot of things. And I think one thing that I loved about being in the COVID units was nurses who I didn't think, for lack of a better word, were that passionate about their practice, all of a sudden were put in situations where they actually needed to know what a BiPAP was and what it did, and they asked. And so I think taking these moments where things happen that illustrate deficiencies is also a great opportunity to think about ways to do things different. And I think James kind of was hitting on that, but I think it is a time to sort of think about how we can do a lot of what we do differently, because beyond med error, Casey sort of mentioned this, there's errors that happen throughout the practice. They're just not as obvious. This is a good opportunity to rethink everything we do.
Thank you. Casey?
I think this has propelled me, everything COVID, all of it has propelled me to move. I'm actually moving into a leadership position where I still get to stay at the bedside for some of the time. And I think when I was in nursing school, I said, oh, I want to be a CEO. I said I want to be a CNO. And I think like now I'm like, I want to be a CEO of a hospital because nurses, we are the change. We are the people who care about the patients the most. Yes, we care about money, but it's patients first, money second. And I think, and ourselves and patients like first. And I think nurses really like start to think, like if you have good ideas, and even if you don't want to step into a leadership role, think, how can I move our profession forward? And if that is stepping into a leadership role, do it. I kept saying I'd never go to the dark side, but we have to go to the dark side and make it bright, because if not, it's just going to stay dark and it's going to stay dismal. And we need people that actually want to make changes stepping into leadership roles.
Great. Thank you so much. Elisa.
I definitely agree with Casey. I think just taking pride in our profession above all, advocating for ourselves, advocating for our patients. And if you don't want to be in that leadership role, even, because I'm one of those people who will never cross to the dark side. I don't think I will. At least have open lines of communication. Work as a team. I know there's this like big us against them with leadership, oftentimes in terms of administrative roles and bedside nurses. But I think once you find a sweet spot of being comfortable in your own practice and knowing that whenever you're doing right by your patients and right by you, and you are practicing in a safe way, there's nothing that can go wrong in terms of your own job security, at least how I see it. And you need to speak up and fight for changes that are going to be positive to make your work environment safer for you to work in, more enjoyable for you to work in, and safer for your patients to get care in.
Thank you. James.
I think be fearless. Be fearless with like the things that Casey was saying. Be fearless with like, no, I'm staying in this room for 15 minutes while this person is having a blood transfusion. You know, there are arguably 4 to 5 million of us in the United States alone. And if we are all fearless and we are all learn the power, like you mentioned, Elisa, that we have collectively, we can make those changes. And I think we need to stop. I'm going to piggyback on y'all a little bit. Stop fearing administration. Stop fearing going into those roles, right? Stop fearing this. Well, you don't understand what I'm going through because you sit in the office and I'm at the bedside. Like we have to stop. All that is based on fear. All that is based on like, I'm scared that I'm going to mess up. I'm scared that you're going to fire me. I'm scared that you're going to write me up. I'm scared that I'm going to lose my job. All of this stuff. We have to let that go. Because the definition of insanity is doing the same thing repeatedly and expecting a different result, right? And we've just been doing more and more and more of the same thing. And by we, I mean our healthcare system, which we are a part of. So I think we are uniquely positioned as a profession to, should I use one more dumb cliche, to be the change that we wish to see in the world, right? We are uniquely positioned to do that because I love our physician colleagues, but they've been, for some reason, the bosses for a long time, and look where we at. Yeah. It's our turn to be the bosses.
I 100% agree. I want to thank you all for your time. You know, two things that I took away is, you know, be fearless and, you know, be brave. And then the other component is empowerment, right? How are we empowering our nurses to be able to step forward, speak up, and actually truly really advocate for themselves and the patients they care for. So with that said, I want to thank all of you. We want to thank Casey Green, Alicia Hambarchian, Dr. James Simmons, and Joseph Castley. And hopefully we'll do this again soon. Thank you.
Thank you, Dr. Taya. This is great.